Hello, my name is Mohammed Sabra, and I'm a first-year cardiology fellow at Henry Ford Hospital. I will be presenting our case today entitled Seek and You Shall Find the Wolf in Sheep's Clothing. I have no relevant financial disclosures. Cardiac amyloidosis leads to restrictive cardiomyopathy, which is caused by tissue deposition of misfolded monoclonal immunoglobulin light chains, AL, causing AL amyloidosis, or age or mutated transthyretin, causing transthyretin-related amyloidosis. Recently, there has been growing enthusiasm about ATTR cardiomyopathy, and this is mostly related to the imaging techniques that allow the earlier diagnosis without the need of endomyocardial biopsy. In addition, there has been development of treatment therapies that help in slowing down the progression of the disease. ATTR cardiomyopathy is frequently overlooked in patients with heart failure, and early identification of ATTR cardiomyopathy is crucial because the institution of those therapies before the development of end-stage heart failure could help slow down the progression of the disease. We present the case of an 88-year-old male with a medical history including lumbar spinal stenosis, carpal tunnel syndrome, hypertension, right bundle branch block, and paroxysmal atrial fibrillation, who presented with complaints of bloating, constipation, back pain, and worsening abdominal pain. On admission, he was found to be in atrial flutter with rapid ventricular response. His high sensitivity troponin was checked and found to be elevated, peaking at 127. The cardiology team was consulted for further evaluation. An echocardiogram was ordered, which revealed a left ventricular ejection fraction of 57% and a significant increase in left ventricular wall thickness, with an interventricular septal thickness of 2.35 centimeter, and left ventricular global longitudinal strain measured to be 8.3% with a relative apical sparing strain pattern, as shown in the figure below. A technetium PYP scan was ordered, which showed increased myocardial uptake compared to adjacent bone and diffuse myocardial uptake. No monoclonal free light chains were observed on pneumofixation. Ultimately, the patient was diagnosed with TTR amyloidosis. Our case highlights the underdiagnosis of ATTR cardiomyopathy in patients presenting with clinical and echocardiographic findings suggestive of cardiac amyloidosis. Historically, ATTR cardiomyopathy was considered rare, but its true prevalence is difficult due to the under-recognition of the diagnosis. This is related to the mistaken assumption that cardiac amyloidosis can only be diagnosed at expert centers through endomyocardial biopsy, in addition to attributing the presenting signs of cardiac amyloid to aging, hypertension, hypertrophic cardiomyopathy, or heart failure with preserved ejection fraction. ATTR cardiomyopathy is a multisystem infiltrative disease associated with non-cardiac soft tissue deposition, such as carpal tunnel syndrome, lumbar spinal stenosis, biceps tendon rupture, and autonomic or sensory neuropathy. Detailed history and recognition of these red flags in elderly patients presenting with troponin elevation and heart failure can lead to earlier diagnosis. Our case emphasizes the under-recognition of cardiac amyloidosis in patients presenting with highly suggestive clinical signs and associated echocardiographic findings. One can easily miss the diagnosis of cardiac amyloidosis when it's right under their nose. ATTR cardiomyopathy is no longer considered a zebra diagnosis. Clinicians should maintain a high index of suspicion for cardiac amyloidosis when patients present with clinical signs, considering its now recognized clinical significance.